Today we'll be talking about injection noradrenaline. Now we know that noradrenaline is one of the first vasopressor of choice whenever we intend to increase the blood pressure. So whenever we need to increase the blood pressure in ICU setting, that is indicated for so many reasons. The patient, whoever has hypotension, that can be because of hypovolemia, that can be because of sepsis, that can be because of post MI, or that can be because of any reason. That time to increase the blood pressure, noradrenaline is one of the best injection to start. Now it is indicated for shock. It is definitely an adrenergic system drug. That is the reason why we use these drug. Now, when we talk about noradrenaline, it has some features. It acts on alpha 1, alpha 2, beta 1, and beta 3, and it has no beta 2 activity. What does this mean is I'll tell you in very short. Now we know alpha 1 and alpha 2, these are the two alpha receptors, these are adrenergic receptors, which actually act on arterioles and veins, and they cause vasoconstriction, they increase the blood pressure. So this is one way through which the NORAD acts. Actually, it acts on alpha 1 and alpha 2 and it increases the blood pressure. This is the mechanism of action. Second thing, it also acts on beta 1. And usually we know that beta 1 receptors, these are present on heart. These actually cause cardiac stimulation. They not only increase the heart rate, but they also increase the force of contraction. So they cause tachycardia and they cause increased contractility of the heart as well. As we know, beta 1 has some other functions as well, like it causes release of renin from the kidney, and this renin again causes stimulation of angiotensin 2, aldosterone. They cause sodium and water retention, and this also helps to increase the blood pressure. And beta 1 along with beta 2 and beta 3 cause lipolysis, so as it increases the uh, fatty acids in the blood, which can be utilized to increase the glucose into the bloodstream. And beta 1 has one more activity, that it causes secretion of ADH from pituitary gland. This ADH, that is anti-diuretic hormone, causes salt and water retention. More is the salt and water retention in the blood, more will be the blood pressure. So overall, this beta 1 tend to increase the heart rate, force of contraction. But in NORAD, this beta 1 stimulation is much less compared to alpha 1. So we know that this noradrenaline basically has much activity on alpha 1 and alpha 2. It also acts on beta 1 and beta 3, but this activity is significantly lesser when compared to alpha 1 and alpha 2. Whereas this beta 1 beta 3 activity is markedly present in adrenaline. That is the reason why adrenaline is used for cardiac arrest, bradycardias, post cardiac arrest, because it has marked effect on beta 1 compared to alpha. So, this NORAD also has some activity on lipolysis, so it may also increase some kind of sugars, or it can cause some increase in sugars. We know this beta 2 activity. Beta 2 receptors are present on bronchi, it causes bronchodilation, as well as they cause dilation of these arterioles and veins. That is the reason why beta 2 stimulation causes hypotension or fall in blood pressure. So, NORAD has no beta 2 activity. That is the reason why there is no fall in BP. Whereas adrenaline has this beta 2 activity, so it can increase or decrease diastolic blood pressure. So this beta 2 activity is not seen with NORAD. That is the reason why fall in BP is not seen. Whereas this NORAD or noradrenaline has marked alpha 1 activity. That is the reason why there is intense vasoconstriction and that causes increase in blood pressure. So this beta 2 activity is not present with injection noradrenaline. So there is no fall in blood pressure. These beta 2 receptors actually are implicated. These act on liver as well as muscles. On liver, they cause increased glycogenolysis, and it causes hyperglycemia. And on muscles also, they cause glycogenolysis and increased hyperlactic acidemia. So this, as there is no beta 2 activity of noradrenaline, there is no hyperglycemia, there is no hyperlactic acidemia per se. So this is in short the beta 1 activity, which actually these receptors are present on heart, which increase heart rate, increase blood pressure. Beta 2, they are present on liver, which causes increased glucose, and beta 2 are also present on muscles to cause increased lactic acidemia. But these beta 2 component is not seen with noradrenaline, not seen with noradrenaline, whereas these are seen with adrenaline. So when we compare this adrenaline versus noradrenaline, NORAD has activity mainly on alpha 1, alpha 2, beta 1, beta 3, but not beta 2, whereas adrenaline has activity on beta 1, beta 2, and beta 3. So that is the reason why this NORAD doesn't cause any vasodilation, whereas with adrenaline, because of this beta 2 activity, there can be fall in diastolic blood pressure. But because of the significant alpha activity, beta 1 activity, there is increase in systolic blood pressure as well as mean arterial blood pressure with adrenaline. Whereas with noradrenaline, you will get systolic blood pressure will be high, diastolic blood pressure will be high. That is the reason why mean arterial blood pressure will be high. And it has very much less activity on beta 1 compared to adrenaline. That is the reason why we don't see much heart rate variation with noradrenaline. So this is one good thing of noradrenaline. Whenever a patient of hypertension has tachycardia, noradrenaline is a much better option compared to adrenaline, because adrenaline, it has marked effect on beta 1 and it can cause intense tachycardia. That is the reason why it can cause arrhythmias. This risk is much less with NORAD, as it will not increase the heart rate. So adrenaline will markedly increase the heart rate and heart contractility. That is the reason why we give that in cardiac arrest patient to cause cardiac stimulation, as it reduces the refractory period. And as it can have the extensive beta 1 activity, the risk of arrhythmia like SVT, VT, VFib is there with adrenaline. So overall, NORAD can be used in septic shock, hypovolemic shock, cardiogenic shock with stable heart rate, as it has much less impact on heart rate. And how do we usually give this in ICU? It's very simple. We simply give 1 to 2 ampoules of injection noradrenaline in 50 ml NS, and we start it at suppose 1 to 2 ml per hour. We see the blood pressure over a period of 10 minutes, 20 minutes. If the blood pressure is not sufficient to give good blood pressure, good blood volume, and good urinary output, then we usually increase the NORAD adrenaline infusion by 1 to 2 ml per hour or 1 to 2 ml per hour till we get a acceptable blood pressure and systolic blood pressure. And systolic blood pressure range can vary from patient to patient. A thin patient with EF of 20-25%, 80 can be sufficient. 80 millimeters of mercury of systolic blood pressure can be sufficient. But if the patient is like 70 kilogram, 80 kilogram with good cardiac function, then at least systolic blood pressure of 100 or 110 millimeters of mercury, so that there is good renal perfusion and we get good urine output. That systolic blood pressure is target, and that is how we increase the NORAD infusion levels to get a good systolic blood pressure. So this is all about NORAD versus adrenaline today. Thank you.